So please join me in welcoming all of our panellists. And just while they settle in, we're going to do 2 quick Slido questions. The first question is, if you can scan the QR code again, has any patient or family asked you about voluntary assisted dying? That's the first question. Just to get a feel for how, I guess, how much this is featuring in your professional life. We'll see the results soon, will we, Phoebe? Oh, yes, we will, she says. Is it not working? We could go, 2 seconds. Here we go. So 100% of people, but how many people's that? Here we go. Yeah, I would be surprised if it was 100%. Okay, so roughly half of you are saying that people have asked you about VAD. And then our second question, if we can go to that one, is whether you've accessed information yourself on VAD, like the New South Wales Health website or the Health Pathway. Okay, so about roughly half of you have accessed information, half not. Maybe we should put not yet. I'm sure you'll be accessing it after today. So thank you, panellists, for being here. I want to start with you, Prue, because we've already heard from Liz that there's huge interest in VAD in Queensland, and from Charles that there have been about 200 plus applications here in the Hunter region. What's the demand like in Central Coast?
Can I answer that by saying it's nice to sit down? So
Sure.
there's about 350,000 people on the Central Coast. We're about 60% on from the activity that was tipped for the population data. We've had 100 referrals in the first 6 months. And I'd say our VAD patient looks like a person who's entering their terminal phase. We've had a really sort of, we're having late conversations, and about 2/3 of our patients are dying before they get through process.
Wow, thank you. So we can take questions from the audience. I have tons of questions, but actually today's all about you. So what would you like to know from this very esteemed panel of experts who are right there at the front line experiencing the demand from the community for this service? And we also welcome questions from our online participants. Would anyone like to start us off? Yeah, we have one down the front here.
I just would like to know what medications are used, which oral medications, and which IV ones you use.
Yeah, did you want to?
Did you hear the question?
Yeah, I heard the question. I wondered if this question would come up, and my fellow panellists are kind of nodding. I mean, there's a bit of discouragement about talking about the actual drugs, and one of the things is if I tell you, and this goes online, then potentially we're in breach of the Commonwealth law, which is using a carriage service to provide information to people about how to kill themselves. So, I mean, that law, I doubt that anyone's going to try and enforce it, but...
Charles, we do have 100 people online as well.
Yes.
Today.
Yeah. So all the more reason that we don't go there.
But you can go to the MAID website and all the medicines are.
Well, exactly. I mean, this is why it's kind of it's a bit of a farce, to be honest. It's just each state has made different rules about how they're going to deal with this Commonwealth law, and it's all a bit of a farce. And hopefully the Commonwealth law will be repealed, but for the meantime, everyone's being a bit cautious.
Prue, did you want to add something there?
Yeah, I'd say in practice, we're really transparent during administrations, working on the floor, working with different teams, and I think it takes away from taboo, just exposing the kids. They're in a theatre environment, they're everyday agents that are used, and I just think it demystifies it when health professionals are aware.
Okay. We have another question over here.
We actually have a resident at the facility that I work at who applied for voluntary assisted dying but was rejected. Obviously, he didn't fit the criteria in some aspect. As he has Parkinson's. As his disease progresses, can he then come back and reapply, or is it a no? Because he was told it was going to be a no if he ever did reapply.
Well, I possibly know who you're talking about, but
I did wonder that
as
too.
you can imagine, it's a small town. But I'll answer it in the abstract. I mean, Parkinson's disease, is a neurodegenerative disease, and the debate with any patient with Parkinson's disease would be around the prognosis and whether it was less than 12 months, which is the requirement, and so. Particularly in the early days, we would normally get, there's a provision within the legislation, although the coordinating and consulting doctors mostly make their own decisions with some informal discussions sometimes with an oncologist or whatever, but with someone like with Parkinson's, which is usually slowly progressive, we would normally make use of that provision to get an expert neurologist to give advice, and then we'd usually kind of follow that advice. But in answer to your question, certainly, there's no reason why anyone who's rejected on prognosis grounds can't come back to us, and we usually say, look, you're not meeting the criteria now, but go back and see your oncologist or go back and see your neurologist in 6 months if you feel that things are deteriorating.
Thank you.
We have a question down the front here.
My question is for Dr. Charles. You freaked the life out of me when you mentioned that oral consumption can lead to loss of consciousness and then can be up to 10 hours post. My fear is that they continue living. I mean, I'm not going to ask you about the medications because I don't want to know, but is there a chance that after those 10 hours they could still be alive longer?
Well, they still, I guess there's a couple of things bound up there. One is what are they experiencing, and I'm not privileged to explain that, but the general consensus is that they're experiencing nothing, and that's what we tell them, that you're going to go to sleep in 5 to 10 minutes, and we're really telling you about the potential for 10 hours for your family's sake. We're not worried that you're going to be suffering at all during that time, and then the usual process are followed once they're believed to have been died. It's got to be verified by a doctor or a nurse or an ambulance officer that they've died. Is that what you were getting at?
It's more the fear that it hasn't worked.
Apparently, what we're told in our training is that it's never not worked. The doses are huge overdoses.
I'm both a doula and an ICU nurse, so I've lived in both dimensions.
Yep.
It's just a case of if we're going down this path.
Yeah.
Could we get the microphone down here, please? Just think mindful of our online participants so they hear what's underlying your question there.
So I'll just repeat my underlying fear. I mean, doula, intensive care nurse. In the intensive care world, bucket loads of drugs, drips, cannulas. We don't do VAD in ICU.
Yep.
But it's a different world.
Yeah.
In a doula, at home, being there as the carer, the support person, my personal Holy Jesus, Mother of God figure. I might be Catholic, but I'm very VAD pro. What if it doesn't work?
So there's the legislation has been written with a fair bit of the states have set things up with a fair bit of concern about that. And to my knowledge, and I'll defer to my colleagues, no one has ever failed with this. And the intravenous, for example, you mentioned cannulas. We're asked to put in 2 cannulas, so there's a backup plan. So yes, you know, no one wants that to happen where it all goes to crap. Yep.
I can say in Queensland we've had, I don't know, over 600 deaths now. It's successful in every instance. And when you say sometimes it goes to 10 hours, that's a very, very rare event. We have had one of those in Queensland, but if you take this substance, it is such a high dose, it will kill you. And I've only ever read of one case study where it didn't work, and that was somebody in America who obtained this through the dark web, and he was a depressive. He took the substance, almost immediately changed his mind before he fell unconscious, told his mother what he'd done. It happened that the ambulance was next door. They came in and revived him. He was in ICU for about 3 months with very intensive support, and he actually did live, but he was never the same again. But that was one case study.
Before we go to the next question, Prue, did you want to say anything? You don't have to.
There are things that they put in place, like they fast the patients for 4 hours. It binds to proteins, and if the patient does have a milk product, it does delay that first past effect. So I've definitely, in the examples that I've seen, it definitely makes a difference if the patient's fasted, but it also depends on their underlying pathology.
Thank you.
Yep.
We have a question over here.
Thank you. I was just interested, after seeing the team structure up on the screen before, if there are plans to have social workers within the VAD teams.
Yeah, that has been sort of discussed in the funding, and I think, you know, so far, I guess there's a fair bit of multitasking on our team, and I think we probably feel like so far we've managed without sort of having a dedicated social worker. And I guess the other thing to say about that is that we don't want to kind of take over the sort of services that are already in place when we see a patient. We don't take over their palliative care. We keep their palliative care involved, and you know, if they've got contact with a social worker, then we'd expect that to continue as it has. But yeah, look, I guess we're picking up some of the work that's traditionally the work of a social worker, but I don't, at this stage, that's sort of, the funding is kind of there, but we haven't committed to adding that.
On the Central Coast, we are trying to get HSM2 as a role, where because of our size, you know, our team looks like me, and then 14 VMOs who work in a fractional capacity, just VMO hours, and I've got a 0.2 clinical lead. So at a bare bones service, I have definitely expressed the wish for onboarding a social work as part of the complement for a new position.
And I have to agree, I think in Queensland, because my service is going across the whole of Queensland, we have 2 FTE social workers and 1 senior psychologist, and they are, I believe, are all utilised to the full capacity of their role. So I think there is great value. Somebody mentioned earlier the concept of disenfranchised grief. There's been a lot of talk about that around VAD. If somebody has VAD and they're in a community where it's frowned upon, what do they do with that grief? How do they process it both pre and after death? If that's real in Australia, don't know, we've got to do the research, but I certainly think that social workers and psychologists are of value here.
Thank you very much. We have a question down the back here in the room.
Hi, I just want to go back to the substance. If the patient had a sublethal dose because, say, they fumbled or they were frail, and then they suffered a brain injury and lost capacity, is there what happens then? Do they presumably just have to survive in that state?
Sorry, if they take a sublethal dose
So-
and...
say if they stumbled
Take a
and
quarter of the
lost some of it.
quantity.
Okay, well, of course, we absolutely discourage that, but if that were to happen, almost definitely a quarter of the quantity would kill them. We had a chap who was an alcoholic. He got the instructions that you mentioned before, and he drank 3/4 of a glass of schooner of scotch before he took his substance. He vomited a lot of that up. Nonetheless, he did die. But the thing is, with all of our patients, they have an acute resuscitation plan. I don't know if you have it here or how it's called, but what it means is that somebody says that in the event that other health professionals are called in, this person is not for resuscitation. So all of our VAD patients have specifically a VAD not for resuscitation plan there. So I really just don't know how anybody could survive this,
And,
taken under the conditions that it's been set up for.
and last night at the dinner, someone mentioned that it tastes quite disgusting. So does the patient get an antiemetic beforehand?
Yeah, the regimen, I can mention the antiemetics. So they get a big whopping dose of ondansetron and metoclopramide as well.
And does the time till death up to 10 hours, is that dependent? Can you predict that in any way based on their condition or diagnosis or any other sort of factors, apart from whether they've had something in their stomach?
In our experience, no. In our experience, it's actually been people that, you would think wouldn't tolerate a dose who've actually lasted longer and vice versa. It's not been predictable.
Thank you.
Can we please not focus too much, though, on the people who are right out there on the bell curve?
Yeah.
You know, the median time to death with an oral substance, in our service anyway, is between 15 and 20 minutes. So that's your vast population. And 50% of people are going to die before that. It's a very peaceful death. No cane stoking, maybe a little bit of a snore.
We have one more question here, and then I was going to.
I think you just answered it. I was going to ask about that active dying stage, if you like, following the medication. A bit of snoring, but no chain stoking. Anything else to add to that?
No, it just looks incredibly peaceful compared to a normal palliative death, in my opinion.
Yeah, I completely agree. It's very quick and very. I mean, as everyone in this room would know, families often find it incredibly distressing when a patient is dying, even though the patient is probably not suffering at all, but the gasping and the gurgling just is not well tolerated often by families, and I completely agree that in the deaths that I've seen, there's just none of that. It's just very quick and very peaceful.
Prue?
I would say, given the referrals we've had in, most of our patients are opting for IV administration, which has been a big upswing from what we expected.
Thank you. We have a question from our online participants. Thanks, Phoebe.
Thank you. How are people hearing about the VAD service? Is there any kind of advertising?
You can't advertise VAD. I don't think the Commonwealth would not look kindly upon that. But there is awareness raising and information sharing. We're actually doing one of those tonic things, for GP surgeries about end-of-life care, that it's important to mention end-of-life care to your GP, and the possibilities are treatment, palliative care and VAD.
We have just partnered with Dying with Dignity as an advocacy body. They are now getting some funding to put some awareness campaigns in. When Kerry Chan launched VAD, there was direct sort of instructions around not broadcasting. When we launched, it was a very private type of matter. There was just the position to be fairly apolitical about the launch of the program. So it was a quiet start, but I'd say there were a population of people who are following the legislation, and we saw that in the intake of referrals that waited the first couple of weeks and then they plateaued. And then I'd say now at that 6-month mark, because of the snowball effect and people talking to people out in the community and 6 degrees of separation, we're now seeing an upswing in referrals.
I know there's a
How
lot
are you
of
going to
talk.
cope with that?
Listen, I think I'm getting back up. I got a budget. I got a great budget going forward.
The power of the grapevine is pretty strong. I know there's a lot of talk among people, in an older age group I'm aware of anyway. We have one here and then one last one over here. Please go ahead.
Obviously, everyone here today is working in a space where we reflect a lot personally and professionally. I guess at the stages of various careers, what has entering this space allowed you to reflect on, whether that's personally or professionally?
That is a great question. I think that's a really beautiful question. I think for me, the reconciling between something I've believed in as a personal philosophy and being able to reconcile that in practice has given me the energy to keep going day to day. The workload's been really high, and in terms of refocusing and referencing, and I think the levelling and the opportunity at these consultations to meet the person without any mask or pretense and hear the patients, and it's just an incredibly powerful space to work in. So I feel very lucky to be working in this space, and I thank all the people who have gone before to do all the advocacy work to get this going.
Thank you, Prue. What would you say in response to that question, Liz?
I think for me it's been an evolution both professionally and personally. I started medicine late, but I went directly into palliative care and felt that was the right space to be. But then when VAD was starting to be talked about and many of my colleagues were saying, no, we can't have this, we've got to keep it out of palliative care, I just thought, no, that's not right, This is another palliative treatment and should be seen as same, which I guess is why I stepped into it. I reflect every day on voluntary assisted dying and to see how it can be made better. But more and more, the more people I come across, the more sure I am in my heart and my soul that this is the right thing to do.
Thank you. And Charles, last word.
Well, I think I said earlier that I was ambivalent when I came into this, and I'm kind of a convert. But I would just add that that I actually feel reasonably protected by the legislation that exists in New South Wales, in that these patients, all the patients that whose deaths I've been involved with have been in a situation near the very end of life where they have no other options that are good. And they've had great time to say goodbye to their families often, and I can see myself like in that situation, and I'm comfortable with it because it's kind of an extension of really, to me, of palliative care and good end-of-life care. But there is a big push, and in fact even the ACT has already taken the time limits off, which is a huge change. There's 3 or 4 patients who've been ineligible that I've seen in the last week. And it opens up to them, and there's a big push for dementia, and there are people at conferences who would like this to be open to anyone who's sick of life. And I might feel incredibly different about this whole process if I was asked to be involved in ending the life of someone who was well. Yeah.
I agree.
Thank you. I know this has unleashed a lot of questions for me and for some of you in the room. Fortunately, our panellists are extremely approachable, so as we enjoy our lunch break, please approach them personally if you'd like to ask any further questions. But for now, we're going to go to a break and enjoy some lunch, so please join me in thanking our panellists.